Welcome to Westmead Private Hospital's GP Education Program. Tonight we are joined by urogynecologists Dr. Jenny King and Dr. Lucy Bates and colorectal surgeon Dr. Gary McKay. Today our specialists will be discussing bladder, bowel and uterus prolapse and hemorrhoids, looking at the assessment, investigation and treatment. So to kick the night off, I'd like to hand you over to Dr. Lucy Bates. She'll be presenting on managing uterine prolapse. Lucy has a special interest in prolapse, overactive bladder and incontinence. She has a public appointment at Westmead Hospital and also operates at Westmead Private Hospital. So over to you, Lucy. Thanks.
Hello, thank you everyone for signing in tonight. So we're going to look at uterine prolapse. So I'll quickly cover definitions, maybe a little bit of anatomy, looking at the types of prolapse, what to look for in examination and history, and then more importantly, both conservative and surgical management. So the International Continence Society define prolapse as the symptomatic descent of one or more of the anterior, posterior, or the apex of the vagina, whether or not that's the cervix or the uterus. The cervix, or if they've had a hysterectomy, then the vaginal vault or cuff at the top of the vagina. Jenny will debate me on this, but it is best measured using the POP-Q system. And that's because this is quite a reliable, reproducible system, but Jenny and I agree to disagree on that one. And then of course there's rectal prolapse, which is defined as a circumferential full thickness rectal protrusion beyond the anal margin. So of course I'm only going to be looking at the apex or the top of the vagina, so looking at the uterus. If you look at all the different studies, of all PARIS women, up to 3/4 of them will have some form of prolapse. And the important thing here is only 12% of these women are actually symptomatic. Ideally, if it's not symptomatic, they don't need to do anything about it. They might just be aware that they might have a bit of vaginal laxity, or but they definitely do not need surgery if they don't have any symptoms from it. And of course, physiotherapy may be a benefit if they do have a little bit of prolapse to prevent it getting worse. They look at the SWEPOP study, which was a population-based study in Sweden looking at pelvic organ disorders. And they looked at women who had had only one child, and they followed them up 20 years later. And they found that about 12.8% of women had asymptomatic prolapse. The lifetime risk of needing surgery for prolapse or incontinence is 11%, and hysterectomy is one of the most common operations in Australia, but this is changing. So if we look at the SWEPOP study in a little bit more detail, of those that had had a vaginal delivery, nearly 15% of them had symptomatic prolapse, and only 1% of those had actually received treatment for their prolapse. Whereas if you looked at the woman who had a cesarean section, still 6.3% of these women had symptomatic prolapse. So it tells you that vaginal delivery in itself, or isn't necessary, it increases your risk, but it doesn't. A cesarean section doesn't completely reduce the risk of prolapse. So symptomatic prolapse was definitely higher after vaginal delivery versus cesarean section, but it doesn't alter it if you compare whether or not they had an acute or an elective cesarean section. So what's the cause of prolapse? Genetics plays a huge role in it, and we know that different connective tissue also plays a huge role. So people like Ehlers-Danlos syndrome or Marfan syndrome are at much greater risk of having prolapse just because of the collagen type. Pregnancy itself increases the risk of prolapse, and it's just because of all the stretching and the increased pressure that the pregnancy puts on the pelvic floor. As I've mentioned, vaginal birth does increase the risk, and especially something like a forceps delivery, which may or may not cause levator injury, can increase the risk. And if you've got that levator injury, then your risk of developing prolapse is much greater. Aging and menopause, again, it's a change in collagen that increases the risk of prolapse later in life. And then things that cause chronic increased pressure on the pelvic floor, such as heavy manual labor with lifting or chronic cough or chronic constipation. And some of that's also due to the nerve involvement of the pelvic floor. So what are the symptoms that these women may have? They may come to you saying they've got a bulge or a dragging sensation. Sometimes they might have some bowel symptoms, like they need to splint or reduce the prolapse to be able to defecate. With an apical prolapse, or with a uterine prolapse, they might have obstructive urinary symptoms. So they have to push the prolapse back up to be able to initiate their stream. They might have issues with sexual intercourse, but pain is not typically a feature of prolapse, especially of the apex. And if they've got pain, you need to go looking for other causes. And also they might have some of these symptoms but not actually have any prolapse as well. So this is the little bit of anatomy that I think I will discuss, and we just look at Delancey's levels of support. So if you look at the top, you've got your level 1 support, and that's what basically holds up the uterus. So that's the cardinal and the uterosacral ligaments. They attach around to the sacrum and they suspend the top of the vagina and the uterus and the cervix. Your level 2 is the endopelvic fascia, which connects along the mid-vagina, and that attaches laterally, and that can often be what's damaged through childbirth. And then the level 3 is the perineal body, and it's the fibers of the perineal muscles, and that provides support to the lower vagina and urethra. And also important because it's often continuous with the external anal sphincter, so it's important in incontinence, anal incontinence as well. So when you're taking a history, what are the important things to ask? How long it's been going on for? Often women are embarrassed by these things and they've been putting up with for a while, or equally so, they've panicked and gone, oh my God, there's something falling out of me. I noticed a bulge in the shower, so they may present relatively acutely. They might have obstructed voiding or obstructed defecation and have to be able to reduce the prolapse to be able to open their bowels. They might, I just have to remove this because I can't remember what I've said there, have a dragging sensation or alteration in their sexual function. And often the sexual function can be psychological as well. So there's more to it than just they're like, oh my God, I can't have sex because I've got this thing hanging out of me. And as well as the bladder and bowel symptoms. Prior history is really important. Have they had previous gynecological surgery or any other abdominal surgery as well? Their past medical history is also important because if they've got things like a chronic cough or a connective tissue disorder, then that's important as well. Of course, their obstetric history is important. So whether or not how many children they've had, because the increased number of children you have, what the size of the baby was, all increases your risk. Also taking the medication history. So medications that you might want to stop or might be contributing, like an ACE inhibitor contributing to their cough, might be needed to be changed. Also vitamin supplements and over-the-counter things like fish oil, ginkgo biloba, ginger, they all increase the surgical risk of bleeding, so important to know that they're on those. And also importantly, what else they've tried. So when we're looking for examination, I always start with the simple things of doing their BMI and looking at their overall patient an abdominal examination, because it's not uncommon to find abdominal masses as well, more so with other types of prolapse. Whether or not you examine them in the left lateral or semi-recumbent, I find it easier in the semi-recumbent because that's how I learned to do it. Prolapse should be measured on their maximum Valsalva. If it's hanging out like in this picture, it's pretty obvious, but sometimes it's not. So you may need to either use a bivalve speculum, which you've taken apart. So you're just using it to look for each of the 3 compartments. And sometimes even when you've examined them and you've got them to strain, you're not really seeing much. You might need to get them to stand, and then gravity can help. Also, sometimes prolapse symptoms can be worse at the end of the day, or even if they're still menstruating at different times of their cycle. So the POPQ was designed as a way of coming up with a way that was easily reproducible. And it looks at using the hymen as a fixed point, and they've got certain points. So there's a point which is the AA point or the AP point, which is always 3 centimeters from the hymen. So that can only ever be 3 centimeters above or below the hymen. But even if you just use the modified POPQ, which is looking at the most dependent portion of the prolapse, is a fairly good accurate point. And using the C, which is the cervix, and how close to that it comes to the hymen. It also gives you important information about how wide the genital hiatus is and what their perineal body is like, because that can also contribute to their risk of prolapse. And then you stage it according to that. And these are the other scoring systems that have been used in the past, which aren't quite so probably anally retentive and sort of more of a guide as to how far down the vagina it comes. So if we look at a case presenting, a 48-year-old presents to the GP with a lump in her vagina. She's had 4 children, all of which were vaginal deliveries, and the first of which was a forceps. The prolapse is usually worse at the end of the day, and she actually has to sometimes push it back up to be able to wee. It's associated with some lower back pain, a dragging sensation, and it's always worse around about the time of her periods. She's had previous multiple laparoscopies and laparotomies for ovarian cysts. And if I was there in person, I would have asked you guys what you wanted to know, but it's important to know, has she tried anything? Is she able to retain tampons, her sexual function, and examination findings as well. So most of her, she's got a BMI 5, most of which is truncal. So that's something that really ideally should be addressed as well. We know that being obese increases the risk of recurrent prolapse if they proceed to surgery. Then if you perform a POPQ, the important thing here is that when she was supine, the cervix came to just above the hymen. And like all prolapse, it wasn't isolated. She's got a stage 2 cystocele and a bit of a stage 2 rectocele as well. She had a normal sized retributed uterus. So what can we do for this 48-year-old? So if we use the Royal College of Obstetricians and Gynecology guidelines from the UK, basically she's bothered by this. So we need to look to see what other symptoms she has as well. Looking for a post-void residual, making sure that she doesn't have urinary leakage as well, because they often go part and parcel together. Once we do that, we can look at just wait and see what happens, look at lifestyle interventions. The weight loss itself won't improve her prolapse, and often it makes them more aware of it, but it will improve her outcomes later on. And if we look at the box down here, it looks at the conservative management and then proceeding on to surgical management. So would she be a good candidate for a pessary? Probably. So, she's young, she's probably about to approach menopause, and that's often the worst time to be doing surgery, just because of all the hormonal fluctuations. For some reason, they don't recover as well. What else do we need to do? What else do we need to do? I thought I'd deleted the slide, sorry. And other options that we can do. So if they're postmenopausal, putting them on vaginal estrogen can often help plump the tissue up, plus it makes them a lot more comfortable, and it can decrease the awareness of their prolapse. Physiotherapy is really important. The idea of the physiotherapy is that it helps bulk up the muscles, and so it helps improve the function of the muscles. So the POPI study really looked at this, and they looked at, it was an RCT where they looked at women who had an individualized pelvic floor program designed for them, with the aim to building up to be able to hold on for 10 seconds and perform 50 quick flicks 3 times a day. And at the 6 and 12-month marks, they had a significant improvement of their prolapse symptoms and fewer interventions in the control group. And then there's all these different types of vaginal pessaries. So as you can see here, this is a woman with prolapse who's had a previous hysterectomy, and you can see here that the pessary is sitting nicely holding everything up. And there's multiple different types of pessaries that can be used. And a lot of the physiotherapists now, if it's a simple prolapse, are using pessaries, are trained to fit pessaries as well. So when you look at surgical management of the apex, there's different ways that you can approach it. And not all of them need to involve a hysterectomy. So you can do a uterosacral ligament suspension with from an abdominal approach, or a sacrospinous hysteropexy where you keep the uterus in place and use the either bilaterally and help hold the uterus up from that approach, or a sacrospinous hysteropexy where they use mesh to attach from an abdominal approach to attach the uterus up to the sacrum. So, just because the uterus is falling out, does that mean that we actually have to remove it? And the answer is actually no. There's some quite good studies now that have come out showing that leaving the uterus is as good, if not better, than taking out, performing a hysterectomy and some sort of vault support. So if you looked either at a vaginal hysterectomy with uterosacral ligament support versus uterine preservation with a sacrospinous hysteropexy, they actually had leaving the uterus improved the vaginal length, it decreased the blood loss, they had less pain and shorter hospital stays. The use of transvaginal mesh, unfortunately, is not so available, but in certain cases it's still beneficial for those women. And actually leaving the uterus behind meant that they had less mesh exposure rates and fewer reoperation rates for mesh exposure. They had less post-operative bleeding and decreased blood loss. And sometimes it's actually not the actual uterus. The uterine body could be well supported, but they can have a big, long, floppy cervix that's coming down. And in those cases, just removing that cervix, using such as what's called a Manchester repair, but basically amputating that cervix, can actually give you really good outcomes as well. There was a lovely study called the Save You study, and basically they compared the sacrospinous fixation versus vaginal hysterectomy with vault support. And they initially wanted to see if it was non-inferior. And at the 12-month mark, it was definitely non-inferior. However, there was a shorter operating time, less blood loss. But interestingly, at the 12-month, there was higher rates of posterior wall recurrence in the vaginal hysterectomy group. At 5 years, they've now been able to follow these women up for only 1% of women in the groups had a failure of the apex in the sacrospinous hysteropexy group versus a lot greater, versus 7% in those that had the vaginal hysterectomy. Which is quite good evidence to show that leaving the uterus is actually beneficial. So if we have a young woman, she's just had her first baby 4 months ago, she's still breastfeeding. She had a vaginal delivery complicated with forceps requiring a large episiotomy, which then broke down. She's got a bit of a backache, a dragging sensation, and a rather significant history. On examination, she's got a very weak pelvic floor. She had a BMI of 26. The tissue looked a bit pale, and the cervix comes down to 2 centimeters above the hymen at maximal valsalva. So when you're looking at this woman in particular, what can you do for her? Physiotherapy is going to be important. She's still only 4 months, so she's got time for things to improve a little bit. Vaginal estrogen in this context is actually not a bad thing to do, especially if they've got symptoms of vaginal dryness as well. A pessary in these women is actually probably not a bad idea because it will give them some support. The other thing to highlight is this, she was saying that she could feel a lump. But also, if you're not seeing it, examine her standing, and you might see that the uterus does come down a little bit further. But reassure her that that she may still get some improvement in the uterus and her symptoms, because it's still early days. But in someone like this who hasn't completed her family, then trying to optimize her conservative management for as long as possible is really important. The other thing is none of our surgery is 100%. So you want to try and delay the primary surgery for as long as possible. So for take-home messages, if you're examining a woman and you discover that she's got a bit of prolapse and she's not bothered by it, you don't really need to do anything by it for that woman. Although sending her off to see a pelvic floor physiotherapist is really could be beneficial, because we do know that at least 50% of women don't contract their pelvic floor correctly. If they're postmenopausal, vaginal estrogen will definitely help. There's a definite role for pessaries, and if you take home anything today, it's that hysterectomy is not always required for prolapse alone. At this unit, they need to have a very good reason to have a hysterectomy. All right.
Can you hear?
Lucy, I have questions here, Lucy.
Yes.
So urinary and bowel symptoms, do they always herald a degree of uterine and or bladder prolapse, pelvic floor weakness?
That's a very good question, and I would probably say no, because there's so many other things with the urinary and bowel symptoms, but the obstructed defecation, not necessarily the obstructed voiding from a big prolapse, then yes, that is causing issues. Anything else to add?
Well, I think Gary can probably tell us a lot on this as well. There are many reasons people have difficulty emptying their bowels, and so often in the past, haven't we, we've thought, oh, we'll fix that posterior wall, and it doesn't make any difference. So I would be very careful about assuming prolapse is causing all of those symptoms without good evidence.
Thanks. Another question, is pelvic floor exercises the only physiotherapy?
The pelvic floor exercises are important, but part of that is making sure that they utilize their core muscles and stuff as well. So, but you need to be able to use your pelvic floor muscles appropriately, be able to contract them correctly. So a lot of women actually can't, which is why it's important we get the physios, because they've got the time that they can spend with the women making sure they're doing it right. And if you've got a good women's health physio, they'll often look at the functional things and look at their back pain and stuff, because it's often all correlated with weak core or divarication of the rectus sheath and things like that all contribute to the functional side of things. So if you've got a good women's health physio, they'll look at all of that as well. So it's not just the pelvic floor exercises, it's engaging the core correctly and looking at the right exercises and stuff that they can and can't do. So, things like crunches are really bad for your pelvic floor, so they can teach them good ways to improve their core strength.
How much time after postpartum would we expect no further improvement in uterine bladder prolapse without intervention?
I'd say usually around 6 months.
Well, 12 months you'll get some re-innovation, and it's always delayed if they're breastfeeding as well. So basically we try and procrastinate as long as possible.
Yeah, there's a study being done down in Melbourne at the moment for women using pessaries postpartum to help support that. So it'll be interesting to see what those results show. So it's watch this space.
Okay. If a lady is not near menopause, so like she's 40 in her early 40s, should she use vaginal estrogen?
I don't usually with them either. If they look like they've got vaginal thinning, then yes, I do. Or vaginal atrophy, or they've got early symptoms of perimenopause, then I might, but usually I don't.
Okay. Is there any role for pelvic ultrasound in diagnosis, or is it purely clinical examination?
Depends who you speak to.
Don't get us started. We should diagnose prolapse by looking, right? We get very shitty when we get a referral that says, oh, so-and-so's ultrasound says she's got this much prolapse and nobody's looked. It can be useful, but they need to be examined and everything else taken into account. Sorry, it's one of my pet hates.
Yeah. Dr. King and I are in agreement on that one. So look, you know, my theory is with ultrasound, it can be useful for those that report symptoms that you're not seeing clinically, but more often than not, what you can see clinically is just as good as what you can see on any form of imaging, if not better.
Okay. Does Pilates during pregnancy help prevent prolapse?
It's not going to do any harm, and it probably is beneficial because it teaches them how to use their pelvic floor correctly. So it's not something that I would say no to, and it's definitely, especially if they're doing it with the women's health physios, then they do a lot of work on looking at their core and stuff through pregnancy.
Okay. Just a couple more questions, then we'll hand over to Jenny. Is there a presumption that the uterine prolapse with gradual worsen with age after menopause using conservative management?
Look, it depends on how active they are. So yes, some can gradually get worse with time. Some just kind of stay the same, and some, as they become less active, they get better and everything kind of shrivels up. I shouldn't say that. But as things alter and change, then yes, sometimes they can get better. Okay. So everyone's individual there.
Can oral contraceptive pills and vaginal cream be used together?
I don't see why not.
Okay.
Yeah.
And one last question before you hand over to Jenny. Do you use a Sims speculum if examining in the lateral position?
You can do. I tend to just use a bivalve and take it apart and just use half, because there's not usually many Sims speculums available in clinic.
Jenny has been around for as long as I've been around.
Oh dear, yes.
Quite a long time. As I was looking at her sign off on her email that she sent me, she has a very impressive sign off. She's the director of the pelvic floor unit at Westmead Hospital, senior clinical lecturer at University of Sydney, chair of the New South Wales State Education and Activities Continence Foundation, and chair of the IUGA Education Committee. Tonight she'll be presenting on managing bladder prolapse. Jenny has a special interest in prolapse, overactive bladder and incontinence. She has a public appointment at Westmead Hospital and is dearly loved at Westmead Private Hospital. So I'll now hand you over to Jenny. Thanks.
Thank you. What I wanted to do today, guys, is there's some things that, you know, we never question in medicine. They're sort of accepted. And in fact, after a while, you start to question them. You wonder if they really are as accurate as we've always been taught. So what I thought we'd look at with bladder is some of those misconceptions and some of those wrong things that we can say to patients. Lucy has covered a lot of the stuff about pathophysiology. And if you think about, we always say bladder prolapse, bowel prolapse, uterine prolapse, and it makes it sound as though there's something wrong with the bladder itself. In fact, there isn't. What happens is something's weak. Something in that vagina isn't staying back where it was when we were 20, and it lets whatever's behind it flop in. So if you look at that orange bit on the picture there, that's just the vaginal wall connective tissue, and you can probably see both of the pictures. But basically, all the bladder's doing is falling where that tissue will let it, okay? So it's not the bladder, it's the problem. The same as when talking about hysterectomy. When a uterus falls down, the uterus is an innocent bystander. It purely falls down because it can. So what you need to correct is the loss of support, not the uterus itself, not the bladder itself. And we always think, it always gets called bladder prolapse, doesn't it? Or cystocele is the other term. And in fact, the anterior wall of the bladder is the most hopeless part in our anatomy. If something's going to come down, that's going to be it, or it's what we're going to see coming down. It's, of course, frustratingly also the site of most of our recurrences. So, you know, there are areas in every specialty that break your heart, and recurrent prolapse is ours. Certainly, the bladder is the most likely to come down. What I wanted to get
across, though, is this idea that in fact it might look like bladder, but it's not usually the only culprit, okay? It is rarely, in fact, an isolated cystocele. And this may well be the reason that we have had, up to now at least, such a bad outcome in our surgery. Now, I don't want to bore you silly about this. It's because I'm a very sad person with a limited range of interests. This to me is fascinating, but I know it's not to you guys. But basically, if you're going to get an anterior vaginal wall weakness, you have to have some weakness at the top of the vagina, okay? It is extremely rare to have an isolated weakness on the anterior wall. Now, you also need to have some weakness at the sides of the vagina. And again, Lucy covered this a little bit. We all talk about pelvic floor muscles. In fact, what you've got is the epithelium of the vaginal wall. You've got a little bit of connective tissue behind that. Then you've got your bladder. Now, on the sides of the vaginal wall, you've got more connective tissue, and this joins out to the side wall of the pelvis. And it's only on the other side of that that your pelvic floor muscles connect. So there is a limit to what you can achieve with your pelvic floor muscles when it comes to a really big weakness. So the things that really matter, and this is what I was saying goes against what we all think, the things that really matter is that apical weakness. The top of the vagina is coming down, the side walls are bulging in, and then there's some weakness in the muscles. In fact, the vaginal wall tissue itself is not very important. We all talk about stretching of the vaginal wall, but that isn't the issue. It's much more importantly, loss of attachment. Now, we know that, again, you can see there's a very strong correlation between the top of the vagina coming down. The uterosacral ligaments are just as important as they are for the uterus. And there's some thinking, and this won't surprise anyone, there's some thinking that you start to get a cystocele once you've got about a 10% lengthening in those uterosacral ligaments. And it may be that a lot of our patients start with slightly longer uterosacral ligaments, congenitally longer, like we see patients with enteroceles who have a congenitally deep pouch of Douglas or rectouterine pouch. So these are the factors really. And don't worry too much about this. I won't worry about that one, guys. The levator ani muscle, some of my colleagues talk about ad nauseum, and they would advise everyone to have an elective caesarean section because, goodness me, we might get a levator ani weakness. And yeah, we might, but so has everyone over time, and the world hasn't died from prolapse. So I think you can overestimate the importance of pelvic floor trauma. Most women who deliver vaginally don't have terrible pelvic floor trauma, and we have reasonable treatments for a lot of them. But the levator ani muscle does a sort of loop around the most distal part of the vagina. So as the baby's head comes out, it stretches that bit up most of all because it's the thinnest and it's the smallest, and we still have to stretch it to get the whole baby out. And there is no doubt that if you tear off that distal portion of the levator ani muscle, you're more likely to get prolapse, you're more likely to get recurrent prolapse after surgery. So it's clearly important. We know that most women who have prolapse have some degree of levator weakness, but then a whole lot of people can have levator weakness and no prolapse either. So what we think happens, and again, this is probably a little bit esoteric, as the anterior wall comes down and it comes outside the introitus, we get different pressure on that dependent part of the anterior vaginal wall than on the bit that's inside. And so you're getting this continued traction effect pulling on the anterior wall. So this is why sewing up the perineum nice and tightly can make some difference to the anterior vaginal wall and where the levator ani comes in. But the important bit, despite, I'll show you something on our anterior repair shortly, despite the way that we've traditionally repaired our anterior vaginal wall, that is a very minor part of the weakness in this area. So less than 20% of what you see bulging is because the vagina has actually stretched, the vaginal tissue is stretched. It's much more loss of side wall, loss of top wall support. It also explains, I might spend a few minutes on mesh at the end, it also explains why some of the studies looking at the use of mesh as opposed to native tissue repair didn't show any difference. And it's because those studies put a little sheet of mesh over and didn't anchor it anywhere. They just laid it on top of the fascia and closed the skin over the top of it. So basically that just came down when everything else came down with it. So just routinely overlying a bit of mesh is not going to prevent prolapse, but that's not really the fault of the mesh itself. It wasn't properly applied. So if you look here, this is a picture, and I don't know if I can point to things. No, don't worry. This is a picture of an anterior repair process. So here's this bulge coming out the vagina, and we open the skin, the vaginal skin over the top of it, and we peel the sides of the skin out to the sides. Now, with the eye of faith, you can see something underneath that peeled back skin. It's a little bit lumpy and a bit bunchy. That's what we call fascia. Okay, and it's all there is. That's the connective tissue. So you pick up a bit of that connective tissue on the left side and another bit on the right side, and we bring it together in the middle, just like it would call a waistcoat repair. And then you close the vaginal skin over the top of it. I'm rather embarrassed doing this in front of a colorectal surgeon because he'll be going, oh my God, what do you think you're doing? And we really are doing very little. If you think about it, all we've done is dragged some slightly less weakened, stretched connective tissue into the midline. And it will hold for a while and it'll look beautiful for the next few weeks. But it does not correct the defect. That top of that vagina can still come down. The side walls can still fall in. So this is the main reason simple anterior repairs fail, okay, because we're not correcting the defect. So there's very little place of that except to kid yourself that it looks nice for a little while. Now, Lucy's covered most of these things. You need the specific defects that we talked about and the specific weakness in connective tissue, and you probably most of the time need to have had some babies vaginally. But even nulliparous women get prolapse. Even women who've had caesarean sections get prolapse. So quite honestly, age, family history, connective tissue, menopause, weight, chronic straining, okay? Those things are all very, very important. And the bulk of my patients are older patients, particularly once they start minding the grandchildren. So you're at an age where you're losing your estrogen, your tissues are getting weaker, and then you start lifting grandchildren. That really is the straw that broke the camel's back. Now, in terms of symptoms, I think the important thing with symptoms, and again, Lucy has covered some of this, you don't have to operate just because someone notices a bulge. If it's a bladder coming down, if you've worked out there's bladder in it, and they are getting some impact on emptying their bladder or on incontinence, and we'll talk about that a little bit more, then you may need to operate. But just having a bump, just having a bulge doesn't matter. Now, the thing I wanted to get really clear is that having a bit of prolapse, having some of your bladder falling down through the introitus does not make you leak per se, right? So you cannot say to someone, oh, we'll just tuck this up, we'll fix this up, and your leakage will go away. You might make it worse. You will probably almost certainly make it worse in the long term, but just doing a little anterior repair is not a treatment for incontinence, and just having prolapse is not a reason for incontinence. Now, this is the classic picture we give our medical students, and what the important region for control of stress incontinence, now we're not talking about an overactive bladder, the important point is that your urethro-vesical junction, so that line between the urethra and the rest of the bladder, is still in position, that all that connective tissue is holding it approximately level with the bottom third of the pubic symphysis. Now, if it sits there, you can have as much prolapse as you like and you will not have stress incontinence. But you can actually, if you look at the next picture, have a bit of a bulge in the vagina, and most porous women will have that degree of bulge in the vagina. But if the bladder neck is no longer supported where it was, so it's now down below that intra-abdominal pressure area, you can certainly get incontinence. So the important thing there is not to say to someone, well, fix your prolapse and your leak will go away, because it won't. Now, they can certainly happen together, of course. You know, you can have similar pathology in each area. But if you think back to that picture we saw, the pictures we saw of the anterior repair, if I just tighten the skin, tighten the fascia and the epithelium underneath the urethra and the bladder, I might block that a little bit, but I'm not really doing anything in the long term to prevent stress incontinence. So if someone's got stress incontinence, you need a specific incontinence procedure, right? Not just an anterior wall repair. Now, lots of other things can happen, and this is where we start getting prolapses we definitely need to do something about. If you've got a big prolapse, and this lady has a complete uterine prolapse as well as bladder and bowel, you can kink the urethra. So this lady's a giveaway, isn't it? She's got that urethral catheter in, and she actually comes in with voiding problems later in the day, okay? First thing in the morning, you've been asleep most of the night, except for the time she got up for the loo, but you've been asleep most of the night, your prolapse goes back. There's no gravity working on it. And they'll say to you, oh my God, I have to rush to the toilet and I leak on the way. As the day goes on, it is harder and harder to wee. They've got to push the prolapse back. That's a classic description of obstruction due to prolapse. Now, what they'll get is that classic picture, and they might also say to you, I used to have stress incontinence. I used to leak when I coughed and sneezed, but I don't now. And that's because they're getting increasingly obstructed. Okay, so that sort of thing in your history is important. Now, if that lady actually has loss of support around the urethra and at the bladder neck, and you push that prolapse back, she will leak. Now, she will leak because she hasn't got much support there. She'll probably also leak because she's obstructed and there's a leader in the bladder. But this is the other thing that happens when you fix up someone's prolapse, tuck it back, looks beautiful, and they come back to you complaining of leaking, okay? Because they're leaking, that pre-existing weakness was there. So, of course, then you try to say, yeah. Look, really, that was there all along. It wasn't our operation. And they're completely unimpressed with that description, quite reasonably. So that's something else you want to pick up beforehand. Now, probably the most difficult thing that can happen to bladders is if people are obstructed for a long time, they tend to strain. And it'll happen with anyone who's got difficulty emptying their bladder. They strain a bit more, they strain a bit more. And they're really only pushing out that urine because they're straining. Now, you tuck everything back with their prolapse repair without having any idea of what's going on with their detrusor function. And you do a bit of plicating, a bit of tightening on that anterior wall, and you'll find they're the patients who just can't bleed at all post-operatively because they had very weak bladder, very weak detrusor muscle, and now you've added obstruction to it. So these patients, obviously, you not only need to sort out, but you do need to do something with. You're not going to leave that sort of thing. Now, just to make life worse, if you think about obstructed bladders, if you think about men with prostatic enlargement, they tend to get frequency, urgency, irritability, and eventually they can't wee, okay? And they may not present till they can't wee. Any form of obstruction, any form of mechanical obstruction at the urethrovesical junction can actually make the bladder overactive. So it becomes one of those bladders that's contracting really, really hard, trying to make you go, trying to make you leak, trying to get out that wee. So you tuck everything back, you fix their prolapse, and they leak copiously from the minute you tuck everything back because the bladder hasn't learned yet, and it may never learn, hasn't learned yet, it doesn't need to contract that fiercely, that the urine will come out quite nicely. So it's really important for us to warn people that, yeah, you might not be leaking at the moment, but I may make you worse when I tuck everything back. Now, we try and sort that out beforehand with urodynamics because we can see that overactivity. We can see how strong their bladder is, how difficult it is for them to empty. So at least we can say, okay, let's not get too excited here. You're going to hate me for a little while because the leakage will actually be a bit worse. But I cannot treat your overactivity until I fix the obstruction. So any complex bladder, any bladder that's been operated on beforehand, definitely needs urodynamics before surgery. So I've popped in these pictures. One of them's the lady who was leaking before, so that's a bit of a giveaway. I haven't got a pointer. I don't quite know how to do it. Oh, there we go. Look, which of these two ladies is more likely to leak? Now, this is anterior wall coming down in both of them. There's the urethra up there. The urethra is somewhere there. But look at that. She's got quite a tight fold. She's got kinking. Oh, go back. She's got kinking at that bladder neck. She's not going to leak, is she? She's going to have some sort of obstructed voiding. So that lady is more of a concern because she could have denervation of her detrusor and she could have overactivity, which will become a real issue afterwards. I mean, bottom line, a bit of stress incontinence is very easy to fix. A denervated bladder, it's like a, paralysed leg, isn't it? That is hard to fix. And an overactive bladder is also very hard to fix. So this is something that we want to look at. Now, again, this was organised for an interactive session, but I just wanted you to look here. The point I wanted to make, if someone has a really big prolapse, right, it is not just bladder. If you think of the things that can come down, when the vagina turns itself inside out, which this one has done. So this lady's had a hysterectomy and now the top of the vagina has come down and basically turned itself inside out. Now, bladder is only so big. Even 500 mils is only like a 500 mil bag. Bladder is not so big. But the other stuff that can come down is small bowel, right? There's all that small bowel sitting at the top of the vagina. When you see a big prolapse that comes out like that, it is always full of small bowel. Now, there'll be some rectum behind there, but rectum isn't that big either. The only thing that causes huge amounts like this is small bowel. So that lady is going to need something to re-anchor the top of that vagina. And if you look at those tissues, you start to get an idea of why we're so keen on mesh repairs, because there's nothing that I can stitch into that that's going to hold terribly well. These are the patients who've had multiple previous surgery as a rule and do need some help. It's poor tissue. Small bowel will come down and keep coming down. So this sort of thing, this is the line where the bladder joint stops at the top of the vaginal vault, okay? If you think of that back up inside. So bladder comes to there. She is definitely going to be kinked up there as well. But this is all enteroceal. So basically, bottom line, anything big's got to have some enteroceal in it. So this lady, what do we think she might have presented with? Again, there's nothing down here. She's had a hysterectomy. So that's the top of the vagina, which is now the leading part. So that's turned itself inside out. If we look up here, I think that's a little bit of urethral mucosa poking its nose out there. So probably not kinked, if you think about it. This is probably the rest of those little cushions that you get either side of the urethra. And the urethra's there, so probably not obstructed. She will more likely have symptoms. She may have some incomplete emptying, but she'll more likely basically have symptoms resulted to the prolapse itself. Now, this is a lovely lady. She's quite dotty. Some of you may know her. This is a few years ago now. She always dresses like Queen Mary, right? She's a parasol. She has her gloves on. She's a hoot. And she catches the bus everywhere in her lacy clothes and parasol. Brought in by her family because she'd been found at home, been living on her own, found at home, and there was poo everywhere. She was fecally incontinent of urine, and she finally admitted to this terrible prolapse. Now, in terms of, apart from just being a gross prolapse and looking like it's going to break through any minute, she'd also had a hysterectomy. So this, you can be sure, small bowel, there was some rectal prolapse behind it. But as I'm sure you'll talk about, rectal prolapse in itself doesn't necessarily cause incontinence. You need other factors, so it's similar to bladders. So this lady, if you look here, she's not obstructed at all, is she? That you can pretty well see into that bladder down that urethra. So she doesn't have obstructed voiding. She's just grossly overactive and grossly incontinent. But she had a few chest problems, and She couldn't lie flat. She was only in her early 70s. Now, the important thing about this lady is that up until now, she had been caring for a Down syndrome granddaughter who was very attached to her. She was about 18, the granddaughter. So the two of them were sort of managing at home, and it looked like if grandma wasn't going to be able to be there, they were both going to go into care. Fairly complex family situation. Anyway, this is someone we did do a mesh repair on. I also did something put some extra mesh for her stress incontinence. And look, she's done really well. And I'm telling you this story because only a few weeks ago I was at the vet and she came in with her granddaughter. She didn't actually remember me, but this is 2.5 years later and she's back caring for the granddaughter. She's got her own life. They bring the dogs into the vet. So I took this picture to the Senate inquiry, just so, what was his name? What's the name of that terrible politician? You know, Darren Hinch. Just so Darren Hinch could be rude to me. And because he was the saviour of all the mesh patients, wasn't he? And I was the villain of the piece. He actually said to me, you know, your name's Mud, Dr. King. I thought, oh, yeah, okay, well, my patients like me. But anyway, and I showed them these pictures, which is why I have them, to try and convince them that there is a need for management in these patients. And he tossed it aside on the desk and said, yeah, but they're old. I don't care what you do to me when I'm old. She's only in her 70s, you know, and she gets her life back. So obviously you're not going to see people like this. And I'm sorry, I don't mean to sound like I'm blowing my own trumpet, but really, you know, these ladies deserve care. And sometimes mesh is the only thing to do. But basically, you wouldn't be surprised. Urinary and fecal incontinence, she was terrible. But they're worth looking after. Okay. Again, I was just going to ask you what this is. Now, this is a pretty dramatic example, and people will often be sent to you with, oh my God, it must be cancer. In fact, look, it's pink, and it's a bit adenomatous tissue looking, isn't it? It's a bit grapey looking. That is just the lining of the urethra bulging out. So that's a urethral mucosal prolapse. Now, most typically, when they're not this bad, they occur at between 5 and 7 o'clock. And if you think about it, there's not much there, whereas around the rest of the urethra, you tend to have other tissue pushing on it, so it's less likely to bulge. So, as I say, purely urethral mucosal prolapse will almost always respond to topical estrogens. Very rarely it'll get bleeding and obstruction, and you'll need to do something surgically. But yeah, don't panic. It's almost never anything sinister. So I thought I'd just never miss an opportunity to try and set the story straight with mesh. And certainly our problem at the moment is lack of products. We have authorised prescriber status here, and we use other meshes on an off-label thing. We say to the patient, look, this was designed for such and such a procedure, and we're using it on you, and you have to understand that. But we only do it on patients with recurrent prolapse, okay, patients with real frailties. The problem we have at the moment is there are patients who are reasonably young, and you say, look, I'm going to operate on you. There's a 1 in 3 risk that prolapse will come back, that your surgery will fail. But if we need to, you're well enough, you can do another operation. But if you're a little old lady who can't lie flat and you've got a bad chest and you cope at home, but you're not really suitable for 3 hours of anaesthetic, I can't, in all honesty, do an operation that's got at least a 30% chance of failing when I can't bring her back. You know, I cannot, some patients will not tolerate more surgery, and you've got to get it right the first time. You get your badly controlled diabetics, for example, you know you're pushing your luck getting them done at 75. You don't want to be coming back in 5 years trying to fix them up. So there is certainly a place for these patients. And fortunately, in Europe at least, we're getting increasing evidence that for patients with severe prolapse, recurrent prolapse, severe comorbidities, the outcome is better. Now, you will read stuff. There is rubbish in the literature. There is certainly rubbish on social media. We have very good data that mesh doesn't give you cancer. Mesh doesn't give you autoimmune disease. It certainly doesn't migrate. In fact, never goes anywhere. It doesn't disintegrate. All those lovely pictures you've seen of lumpy bits of mesh in fact, are poorly cleaned bits of mesh. And when you scrub them properly after the formaldehyde they've been in, they look fine, just like they just went in, okay? And gosh, you know, we can remove mesh in Australia. We just try not to do it unless there's a very good reason. So that's my little rant, guys. Sorry about that. But basically, I think sister seals don't operate unless they're doing something to the bladder. Good chance they will come back with just a simple repair. Let's look at the other issues. Are they causing obstruction? Are they causing overactivity? Can we leave them? Can we just fill them up with estrogen and pelvic floor exercises and wait? And I'd have to say there's not a very good reason for operating on young people. And I have colleagues who say, let's do it now while you're young. And I actually think that's a bit dishonest, because nothing I do now is going to stop something coming back later, right? We're going to get older. We're still going to stand up. That tissue is going to be more and more past its use by date. So don't operate until you have to. And certainly I'm quite happy to watch patients year after year until they really need something done. Thanks, guys.
Thanks, Jenny. Now I have a question here. What is the reason for women who can't void much when sitting on the toilet but can empty the bladder when they stand up?
Interesting. Usually they would have had some previous surgery. That would be the classic reason. They might perhaps have a very poor bladder pressure, detrusor pressure, and they strain a bit more when they stand up. They need investigating. Sorry, we need to see what's going on with them. I mean, sometimes people can't wee because it's a public toilet, but no, that isn't normal, and I think we better see them.
Thank you, Jenny, for your time. Lastly, we have Dr. Gary McKay, who is presenting on managing hemorrhoids and rectal prolapse. Gary has a special interest in colorectal cancer surgery, pelvic floor disorders, incontinence, colorectal cancer, inflammatory bowel disease, and hernia and general surgical conditions. Gary has a public appointment at Bankstown and Lidcombe Hospital, and he also operates at Westmead Private Hospital, North Shore Specialist Day Surgery, and St George Private Hospital. So thank you, Gary, and I'll hand over to you.
Really, really interesting talk by Jenny and Lucy, and I learnt a lot. My topic tonight is the posterior perineum, and basically, by convention, colorectal surgeons operate behind the perineum, and urogynecologists operate anterior to the perineum. I won't talk too much about the elephant in the room. Does anyone? Well, it's not interactive, but this is an elephant that invaded a family's home in Thailand that was on the news last night. So the elephant in the room's already been discussed, I think, quite adequately by Jenny, and that relates to the hysteria over transvaginal mesh. And I think that Jenny's adequately answered that, and certainly in elderly patients with quite significant morbidity related to their prolapse, there is a role for mesh. Personally, I'm not, conflicts of interest, I'm not sponsored by any mesh company, but I have used mesh in the past, shame, shame. I currently use a biological mesh, Surgisys, which some of the anti-mesh groups are also implicating in their chronic pain syndromes, etc., etc. So I'm probably the villain as well when it comes to that. Traditionally, well, the transvaginal meshes have been the subject of Darren Hinge and other groups looking at chronic pain syndrome, and there's no doubt that there are a subgroup of people who do experience mesh erosion into the vagina. So for the purpose of my talk, mesh is biological these days. I think there are very few people who use a proline mesh for attachment to the anterior rectum for rectal prolapse. We tend to use a biological mesh. The downside of this is that it does dissolve, and there may be a higher recurrence rate. So the definition of rectal prolapse basically is external. So we all know what an external mesh, external rectal prolapse looks like, which can be full thickness or partial thickness mucosal. The internal intussusception is less well appreciated, and often ignored or maligned. And I've even got colorectal surgeons who don't believe there's any role for surgery for the internal prolapse. It's just unnecessary. But if you look at external prolapse, you know, obviously it's annoying, it's hanging out, and it causes mucus discharge and discomfort. But it's not a great step in logic to realise that internal prolapse could cause some symptoms as well. It's just higher up. And the symptoms that it predominantly causes are obstructive defecation, so constipation. So I believe there is a role for surgery for truly symptomatic internal rectal prolapse, also called intersusception. So the differentials. Now, I hope you've all finished dinner and dessert, some graphic photos. This was meant to be interactive. This is clearly not rectal prolapse. It is hemorrhoidal prolapse. And even at med school, I remember being taught that hemorrhoids have radial folds. And you can see that quite clearly. If you look at that, there are radial folds. And you could, on first inspection, you could be easily convinced due to the size of this prolapse that this is actually a rectal prolapse or a mucosal rectal prolapse. But in fact, there are radial folds, and this is just an advanced case of hemorrhoidal prolapse. And we would call this hemorrhoidal prolapse with circumferential hemorrhoidal involvement. Here, on the other hand, you can see rectal prolapse, and you can see the circular folds that are typical of rectal prolapse. So what are the risk factors for rectal prolapse? Well, essentially, the middle-aged to late-aged young, fit, skinny woman with a wider pelvis than a man, particularly if they've had a hysterectomy, are at increased risk of rectal prolapse. If they've had a history of constipation and straining, then they're at increased risk. The other reason middle-aged to later-aged women are at risk is because of menopause, and I think Jenny has discussed this quite well, as well as Lucy. Finally, collagen deficiency has been sort of referred to as being another possible cause, and we know about Ehlers-Danlos syndrome and Sjögren's syndrome, but there are probably undiagnosed collagen defects that lead to rectal prolapse. So the incidence, it is incredibly common, but unfortunately underreported due to embarrassment and also some confusing symptoms. So the symptoms can be quite confusing, even as a colorectal surgeon, trying to work out if a patient with mucus discharge and rectal prolapse is constipated or incontinence can be quite difficult. It is important in the overall management of their rectal prolapse, particularly if surgery is entertained. So you need to take a history. You need to, many patients, by the way, with their symptoms, they're unaware that they have a rectal prolapse, and they need invitation to discuss it because they may be embarrassed about it. So I often ask patients, can you feel a bulge or protrusion at the end of defecation? Do you have to push it back in manually? Obviously, if this doesn't happen, they give you a blank, curious look because it doesn't happen. But if it does happen, it gives them an invitation to discuss their embarrassing condition, which they've spoken to nobody about before, even their partner. You then need to ask about constipation, and it is quite tricky to know which came first, the chicken or the egg. Are they constipated and their straining has led to rectal prolapse, or are they in fact constipated because of obstructive defecation caused by their rectal prolapse or internal intersusception? And at the end of the day, sometimes the only way to find out is to treat their rectal prolapse and see if it improves. Incontinence can be a complicating symptom to sort out. They often describe moisture, but is it fecal incontinence or is it just mucus discharge from their rectal prolapse? Also, the stretched anal sphincter that results from chronic prolapse can cause some degree of anal seepage, and this will oftentimes recover and reduce back to normal diameter once the rectal prolapse is treated. So the examination, increasingly in this modern age, patients will actually come in and want to show you their photos from their iPhone. And, you know, there is a certain personality type where you need to make it clear, set boundaries and say, okay, I'll see 1 or 2 photos. Okay, otherwise you spend the whole day going through their entire gallery of photos. Digital rectal examination is very important. And I've often heard it said, you're better to put your finger into it than to put your foot into it. You can feel for an anterior rectocele, you can exclude a cancer, you can assess the anal sphincter tone. So you ask them to cough, squeeze and relax. And you look at the integrity of the pelvic floor. Does it descend with coughing? Full thickness rectal prolapse is pretty, can sometimes be hard to examine in the lateral bedside examination. And sometimes you need to actually get them to squat, to cough or sneeze, or press down. And you may need to cover the perineal region and advise them not to be embarrassed or worried if a bit of wind passes. But bedside proctoscopy is probably not that useful, whereas colonoscopy can be quite useful. On colonoscopy, you can actually examine them under anaesthesia with Valsalva maneuver in the lithotomy position with a little bit of reverse Trendelenburg. It's amazing the amount of prolapse you can actually create and assess them quite well. Now, this guy, Philip Vladicare from iMed Radiology, is a saint, in my opinion. He does defecating proctography at Westmead Private Hospital. It takes a unique person to do this sort of test where you actually inject radio-opaque cornstarch syrup up the backside and ask someone to defecate while you film them on a radio non-opaque toilet. This is a really useful examination for assessing internal rectal prolapse or intussusception and all the other associated conditions that can be associated with pelvic floor weakness, such as pelvic floor descent, rectocele, which is an anterior bulge of the rectum, or as Jenny King would describe it, a posterior vaginal vault prolapse, and an enterocele or a cystocele. Sometimes they have all 4, rather humorously defined as tetralogy of fallout, for those who are familiar with tetralogy of Fallout. So here we can see a rectocele, and not all rectoceles are symptomatic, and Jenny King has and Lucy have alluded to this. The classically symptomatic rectocele requires the woman to apply perineal pressure, so digital pressure to the posterior vaginal wall to stabilize the rectocele to assist with evacuation. And these are easily seen on defecating proctography. You can see contrast trapped within the rectocele, and these are often associated with multiparity. I've learned from Jenny King how to say nulliparity. It's nulliparous women. I used to call them nulliparous women. Anyway, pelvic floor descent can also be seen on defecating proctography, and this can be improved with Kegel exercises, pelvic floor physiology testing, and physiotherapy and biofeedback. So the treatment options, the first rule, of course, is to do no harm. And, you know, this is Hippocrates' original treatment for hemorrhoidal prolapse, realizing that it's a gravitational problem, is you turn the patient upside down and hang them upside down by their ankles. Now, this clearly can be associated with significant other comorbidity. And the rule of thumb is if it's not symptomatic, don't subject your patients to torture or unnecessary surgery. So conservative management for rectal prolapse certainly has a role. My wife, who is against white sugar, believes that this is one of the best roles for white sugar, is the topical application of sugar to a edematous irreducible prolapse. And this has a classic application in pediatric rectal prolapse, but it can also be used in adult rectal prolapse, where the osmosis caused by application of sugar reduces the swelling and allows the prolapse to be pushed back in. And as has already been alluded to, sometimes a vaginal pessary of sufficient size and well placed can actually keep a rectal prolapse in place and stop it coming back out again. In terms of surgical management, traditionally we've defined the operations for rectal prolapse into those perineal procedures done from below versus those abdominal procedures done from above. And the perineal procedures include the de Lorme's procedure and the Altomeyer's, which are two procedures that get rid of the rectal prolapse from below. They're ideally suited for elderly patients who would not be well subjected to a general anaesthetic and laparoscopic or major abdominal surgery. The abdominal procedures are divided into those without a resection, so a sutured pexy or a mesh pexy. Increasingly, we use a biodissolvable, non-permanent mesh, which is made from collagen. It's actually derived from pigs' mucosal intestine. The resection rectopexy is also called the Freakman-Goldberg operation. I think you've got to be freaking insane to do this operation because it really does add a lot of morbidity. Doing a resection rectopexy increases the risk of anastomotic leak. It really is a very invasive operation for someone with just rectal prolapse, so it needs to be used very cautiously. So traditionally, we look at patients who are suitable, who need surgery. Are they fit for surgery? And if yes, they'll probably have an abdominal operation. And if they're not fit for surgery, they'll have a perineal operation. Abdominal operations are now done laparoscopically, which does reduce the morbidity associated with their surgery. And if they're obstipated or if they're constipated, then sometimes a resection rectopexy may be indicated. So, this is a traditional point of view, and I think we're moving away from resection rectopexies because of the risk of anastomotic leak and sepsis. If there's no obstipation or constipation, then they would be given a mesh rectopexy with a biodissolvable mesh. If they're not fit for surgery, then a perineal operation would be performed. And if it's less than 5 centimetres prolapse, they'd have a de Lorme's procedure, which is where you strip the mucosa off the prolapsing rectum. You do some imbricating sutures to the muscle layer, and then you close the mucosal layer. And it's really quite a fascinating and easy operation to perform. The Altomeyer's procedure is where you have a very long prolapse, it's non-reducible, and an actual resection needs to be performed. And this has the associated risk of anastomotic leak, but it is a relatively easy procedure to perform. So here we see a rectal prolapse with quite a long prolapse, gangrenous at the tip, and this is clearly one that would be better off resected. It's an elderly patient, you can see the skin wrinkles, and this is someone who should have an Altomeyer's procedure where the rectum is resected from the perineum. It's the only operation for this person. I've shown this photo, sorry about the poor quality, because it shows, I mentioned radial folds and circular folds, and this, despite the radial folds, is actually a partial thickness mucosal prolapse. And you can see on the right side, there's actually mucosal prolapse. And this patient would actually have a transanal perineal de Lorme's procedure, which is a procedure described by the Brisbane surgeons, where basically they have a hemorrhoidectomy. But instead of removing a hemorrhoid, you're removing prolapsing mucosa. So again, this was meant to be interactive. This is a Belgian bar, and the other product that has come out of Belgium is the De Hoor's ventral mesh rectopexy, which has received a lot of popularity. And this is where you can see the yellow line, a biodissolvable or permanent mesh is placed anterior to the rectum. So it's called a ventral, meaning in front of the rectum, mesh rectopexy. And the benefit of this operation is said to be the absence of any posterior dissection. So you're not dissecting out any of the nerves of innervation to the rectum. So you avoid a hindgut a hindgut neuropathy. So you avoid dissecting out those pelvic splanchnic nerves. This is secured to the pelvic floor. And this has received a lot of interest and is probably the operation of choice nowadays for rectal prolapse. It's been made increasingly easy with the advent of robotic surgery, with the miniaturized robotic instruments that can articulate in the pelvis and allow for suturing of the mesh with ease. And even I can do this operation. I'm a terrible laparoscopic suturer. The other benefit, of course, is the avoidance of a big abdominal incision. You can see on the right the robotic incisions associated with use of the Da Vinci robot at Westmead Private Hospital. But what is the evidence in support of the various approaches to mesh rectopexy? Well, unfortunately, we're still in a state of equipoise where we really don't know what is better. And there are two big studies that have looked at this, the PROSPER trial and the Cochrane review. And the PROSPER trial was a big study, randomized, controlled, with multiple arms that aimed to answer every possible question about surgical approaches for rectal prolapse. And unfortunately, it was undersized and was inconclusive. So really quite depressing. The Cochrane review, again, basically reviewed a huge number of poor quality controlled trials and concluded that there really is no evidence of one surgical approach being better than the other. So we really are in a state of surgical equipoise, not really knowing what the best approach is for rectal prolapse. Thank you very much. That's all I have to say. And Sandra has asked me for you all to scan the QR code and provide your evaluation.
Thanks, Gary. We do have one question here. Someone wanted to know what the sugar thing was. They missed what you're saying about the sugar.
Okay, so sugar is hyperosmolar, so you apply it to a rectal prolapse, it won't reduce, and it sucks all the water and fluid out and reduces the edema and allows the rectal prolapse to reduce spontaneously.
Great. All right, there you go. All right, so if anyone else has any other, do we wet the sugar?
The sugar will wet itself. No, it's applied dry. That's the whole purpose. It's hyperosmolar. You want to apply a dry molecule that absorbs water, so it sucks the water out of the mucosa.
Can you also apply to hemorrhoids too, Gary?
Yeah, look, my apologies. Due to the limitation of time, I didn't discuss hemorrhoids. So there are some crossovers with rectal mucosal prolapse and hemorrhoid prolapse, and it's almost academic because mucosal partial thickness prolapse and hemorrhoids can be treated in a similar manner, whether it's excision, hemorrhoidectomy, or what I described before as a transanal de Lorme's procedure, popularized by the Brisbane group. There are some more novel agents, techniques such as stapled hemorrhoidectomy or the STAR procedure, which is essentially the same thing. The risk with those is you're leaving permanent staples. There's a risk of stenosis, stricture, wound infection. There's a more recent technique called transanal hemorrhoid dearterialization. It's also called the HALO procedure in the UK, hemorrhoid artery ligation operation. It's called the HALRA in America, and it's basically just using a Doppler ultrasound probe to locate the feeding artery, tying it off, and doing a sutured pexy, which is a suture that lifts the prolapse back up, and that can be useful for prolapse and hemorrhoids. The old-fashioned open Milligan-Morgan hemorrhoidectomy is your default option for really large prolapse and hemorrhoids, and I guarantee you, any surgeon that does this operation, your patients will hate you forever. It's a painful operation, painful recovery, and should be avoided if at all possible. Okay, now Jenny, can you take yourself off mute because this next question's for you. So do you know how to do that? So bottom left-hand corner, there's a little microphone.
Yes, I will just apologise. The fax is coming through, but yes, okay.
So can you explain the pathophysiology of the deep pouch of Douglas to which Jenny alluded in the etiology of some rectal prolapse? So I'm not quite sure if it's for Gary or
yes,
Jenny.
For us, it's intraceal. An enteroceal comes from the top third of the posterior wall of the vagina, and it's really just the abdominal cavity. And some people, that's quite a deeper pouch, and so it's easier for their small bowel to come down. There's all sorts of theories about whether that presses on rectum. Some of my colleagues believe that can press on rectum and cause constipation, and that I find that a bit questionable. It can certainly be big enough to block an anterior wall, but as to why do some people have long arms? Why do some people get asthma? I don't know why some people have a deeper pouch of Douglas. And to be fair, we only see people afterwards, don't we, once they've got prolapse. What we really need to do is look at them through their teens, through their 20s, before and after kids, and see, okay, what really does lead to prolapse? Not just looking at everyone who's got prolapse later and saying, oh, it must have been. But I think Gary will know more about it from a bowel viewpoint.
Yeah, so excision of the pouch of Douglas is an integral part of a ventral mesh rectopexy. And in women in particular who have a wider pelvis, a more empty pelvis, particularly if they've had a hysterectomy, the pouch of Douglas can be quite deep, and they can have virtually non-existent lateral ligaments holding the rectum in place. They basically have an echo chamber. There's not a lot much in there other than their rectum and a big deep pouch. And excision of that pouch of Douglas is critical as part of their rectal prolapse operation, and would be also important for preventing the bladder from invaginating into the rectum.
Yeah. Now, people are obviously very intrigued by your sugar method there, Gary, because someone wants to know if you can apply it to hemorrhoids as well, and how long does it take?
Look, the only reason I put that photo up there is I was trying to put up as many irrelevant photos as possible. So I've never actually used sugar. I'm sorry. I ingest a lot of sugar. I've never used it for hemorrhoids or rectal prolapse.
There's a question here that's off topic. So Eenie Meenie, who wants to answer it? Third degree tears, assessment for planning next delivery, question mark.
Okay, I'll go first if that's all right, because Gary only gets to see the ones we don't fix well. There is a very good protocol. Unfortunately, not all hospitals have the resources. But what we do, if someone's had a previous third degree tear, we have very strict teaching and training. And in fact, my widowed 85-year-old mother only yesterday drove 150 kilometres to the abattoir to pick up some pig's bottoms for me, which she then, she said, and I gave them a slab, dear. And I said, Mum, you don't even know what a slab is. Yeah, oh yes, I do. The grandsons told me. So she gave them a slab for cutting up the pig's bottoms, took them home, washed them because she doesn't think they should have poo on them, and she separately packaged them. So every few months, our registrars have to sit down and do practical anal sphincter repair sessions. Part of our problem is the consultants who haven't all done it, but if we get the registrars, we're right. Now, after that, if presuming someone's asymptomatic, if they're symptomatic, if they've got fecal symptoms, we will scan them and review them earlier. But if they're asymptomatic, we tend to do an endoanal ultrasound at about 6 months. They're over their stress, the scar tissue's settled, and if they have a persistent defect, then we would recommend caesarean section for their next delivery. If they are asymptomatic and they have no defect, if their anal sphincter is well repaired, which is 90 to 95% of our patients, then we say they can have a vaginal delivery. What we know now is that a good mediolateral episiotomy, a well-performed episiotomy, not some piddly little scratch, but a nice decent cut, is absolutely protective for recurrent problems with recurrent tears in the next pregnancy. So we do not have previous anal sphincter injury as an indication for elective caesarean section. They have to be symptomatic, in which case then people like Gary would see them, they'd get their manometry, or they have to have a defect, in which case we wouldn't risk, even if they're asymptomatic with a defect, you worry that they will deteriorate over time. So we do get some who have an awful outcome. We get women whose tear gets infected or breaks down, and they need a colostomy until that heals. And it's always difficult, isn't it? If you have a complication that's very devastating, it's not much fun for that woman if you say, well, look, that's a really rare complication. It's a terrible outcome, but equally there are lots of complications from caesarean sections too. So we have to, we're seeing those more and more. So we do have a strict training thing, a strict protocol for repair, and they're all monitored. But Gary can tell you what happens later on. We don't do well with the cold repairs down the track.
Yeah, look, I would concur with you, Jenny. I think that there are far too many elective caesarean sections being performed, particularly in the private. Sorry about that, Westmead Private Hospital. But it does come down to patient preference, and if they've had a traumatic experience, they're still psychologically affected by it all, then, they'll probably have a caesarean section, and it's hard to argue against that when there are so many lesser reasons for having an elective caesarean section. But yeah, I think the aim should be to try to not turn a natural process into a surgical procedure. Most women can go on to have a natural vaginal delivery with precautions that they have backup plan. If there is a prolonged second stage of labour, that they have a backup obstetrician available.
Yeah.
I have another question here. Are retrovaginal fistulas found in third world countries, seen in multiparous women in Australia? Are they difficult to treat successfully?
That sounds like a question from Emil Farag. Am I right?
No, you are not right. From James.
So what was the question again, sorry? Are they common?
Are they difficult to treat successfully?
Well, you can get an injury. I'll talk about acutely again because that's my area. You can certainly get a tear into the rectum with an anal sphincter injury, or even without it. We call them buttonhole tears, and sometimes the baby's shoulder or elbow will tear right through vagina and into rectum, and the sphincter can be okay. In fact, they are generally very easy to fix and do well, but every now and then you will get someone with a persistent fistula where it hasn't healed well. So again, that's something that Gary would see. We would just try to refer those on to our colleagues. They're certainly not common.
Look, I think you're doing a fantastic job, because I think most of us would, with an interest in perineal disease, would see less than one a year. So they're not a common problem.
Yeah.
I've got one at the moment, which I'm happy to refer to you, Jenny.
No, I've got one referred from Canberra today I was going to send to you. I don't think it's appropriate for me to do a cold repair.
Now, guys, don't fight. All right, well, that concludes our questions.
We hope you have enjoyed this
GP
education session.
So thank you very much.
If you wish to gain CPD points,
Lucy, Jenny,
this activity
and Gary,
is
really
now a quick log
time.
activity, which means you need to head to the Royal Australian College of General Practitioners website to log your own points. We hope you can join us for more of our GP education in the coming weeks. Thank you.